Okay, Brad, on to risk
right.
in the practice.
Well, actually, and I'm thinking about, actually we may have streamlined some things because we did cover some things that I'll be covering in this presentation. Right. So, again, just to increase your awareness or thinking about, this is an overall approach to strategies to minimize risk in the physician office setting. One of the things that I do as a risk management consultant on a daily basis is field like troubleshooting calls from policyholders. And again, like I said, I'm always learning stuff from you guys because I think I've heard everything, and then some new wrinkle comes along and a new issue or a problem or a challenge that you're faced with. And even, as I was sitting in on the Ebola presentations yesterday, we're starting to get some of those questions about liability issues related to treating patients. You have a patient who's in urgent need of care, shows up at the emergency room, but you suspect that they maybe have been, exposed to Ebola. How do you handle that situation? And, if there's a delay in treating that patient, could there be repercussions? These are things that are just beginning probably to kind of surface in the, questions about potential liability and where hospitals and physicians and healthcare providers may be at risk for some things. But again, going back to the physician office setting, I gave that same spiel as far as the, not an attorney, we talk about things that are, that regulate, healthcare is heavily regulated, by laws and regulations, so we can't help but, deal with these things and talk about some of that as well. Overall, on this presentation here, really this is a lot of stuff that you all deal with on a day-to-day basis. Again, it goes to things that are controllable risks, things that you exercise a lot of control over with respect to how you deal with your patients, deal with your staff, how you and your colleagues document in the medical record, how you communicate with patients, informed consent issues, all the kind of operational things that you do with respect to running a practice. And again, these are things that I have an opportunity to learn when I go out and do an office practice assessment. And I'm not doing an accreditation survey. I'm doing a office practice assessment where I'm going to be looking at various issues that that surface when we're looking at or dissecting medical malpractice claims. These are some things that show up kind of on a perennial basis. And, maybe the defense of this case could have been better if there had been better documentation, if there had been, hadn't been a lack of follow-up with the patient, that kind of thing. So, we're going to focusing a little bit on systems issues as well. And hopefully out of that, we can take some of this information and apply some, best practices from a risk management standpoint. We're in the age of technology and, a lot of things. We've got all our toys and devices and things like that. Hopefully they're helping us do our jobs better. I see somebody saying no, because it can complicate things too. And I think sometimes our practices haven't caught up with our technology. That technology is kind of running the show. I've had many folks tell me when I do medical record reviews in the office, and it used to be I would get a stack of charts and look through the paper charts, and now I get, they sit me down in front of a computer terminal, and, I have to learn, get oriented to that system, and there are so many different systems out there. But I'm looking for the same things, though. I'm looking for, how are test results entered? How do we, acknowledge these? How do we communicate them with the patient? How do we follow up? There are standard things that I'm looking for, even though it's a different system and there may be a different way to get to it. And many of you are using different systems. Hopefully you're happy with those systems. Hopefully they do, for the most part, help support patient care. But I know you are struggling with some things. And I have some folks say that sometimes they feel that they are serving technology, that, that they're serving the medical record versus, the other way around. And that's not necessarily the intent. Medical records was supposed to help us in many ways, and it's presented its share of challenges, from that standpoint. Again, keeping perspective on things, I like New Yorker cartoons, and here we have the doctor with the patient, and it said, he's looking at his arm and said, although it's nothing serious, let's keep an eye on it and make sure it doesn't turn into a major lawsuit. Well, you guys don't talk to your patients that way. And hopefully you're not, every time a patient, you go into the exam room, you go, okay, potential lawsuit sitting there, hopefully that's not your thinking, from that perspective. I would say that, we talked about difficult patients, but I think by and large you would acknowledge that most of your patients are good patients, they're compliant patients, but it's the ones that aren't, that subsection or that minority are the ones that probably take up more of your time, and trying to deal with them and trying to help them. So from that standpoint, I definitely applaud, your efforts, and it can be frustrating and challenging at times. It's easy for me being up here talking about things to look out for, what you should and shouldn't do. I'm not practicing medicine, and I would hope that, and I'm not telling you how to practice medicine either, and I would hope that these things that we take away, some of the, the take-home points are that, these are things that, maybe I should look at my practice and do like a little assessment, or have my carrier do an assessment of my practice, have an objective person, outside person come in, look at things, get some feedback on that, and talk to my staff and find out, where are they experiencing challenges and issues and problems or concerns, along those lines. Because there's so much going on in your office on a daily basis with the number of patients you have to see, the kind of the time production pressures and, seeing patients, documenting those encounters, doing all the, the things that you need to do. It's incredible. And also to bring perspective on this as well, usually, I have folks that will call me and say, oh, I have a patient who's mad at me and they're threatening to sue me. What do I do? And then, we talk about the encounter, what happened in the situation. Well, maybe the patient was angry because they were inconvenienced or they're mad about something, but they don't really necessarily have a legitimate complaint or suit from that standpoint. They might have a legitimate complaint, but it's not worthy of the level of suing. And I also say to, our physicians, I say that, even though they've said that and they've threatened that, you've done the right thing in contacting your liability carrier. But I think, from a risk management perspective or from the claims investigator perspective, we're going to tell you that, the patient is venting in some cases, and they would be hard-pressed to take that to an attorney and get an attorney to, because what I'm told by both plaintiff attorneys and defense attorneys is that they want to win cases. And they want a case where they really think they have a chance of winning, okay? Of course, we want that on our side from the defense standpoint, but the plaintiff attorney who's representing the wronged patient or whatever, they want to win as well. And so, there is that and so they're not going to just take on anything. They want to make sure that they have some chance of recouping something from their efforts along those lines. And, you see all the advertisements on TV about, lawsuits or, if you've been injured or if, mesothelioma, asbestos, all these kinds of things, class action suits, things like that. There's all that stuff that's out there all the time. But really, these are the elements of a malpractice suit that have to be, if the burden is on the plaintiff or the patient to bring this against the provider, in that there must be a duty, a breach of that duty, there must be damages and causation. So the duty comes from the fact that there is a doctor-patient relationship. There is an established doctor-patient relationship. There's a breach of that duty in some way, that there's an injury that has occurred, and then the injury was caused by that breach of duty. So it's all kind of tied up into that definition, from that standpoint. And these are all the elements that have to be met. I know in some cases we were facing an issue in California where in some cases plaintiff attorneys, rather than bring medical malpractice cases against providers, they were bringing elder abuse cases on some elderly patients because it was easier to win an elder abuse case versus a medical malpractice case. If it was a patient in a nursing home or something like that, they would use that as a way of getting, what they wanted or the result. So there are those kinds of things that can happen. But again, to bring perspective to it, and it's not always that easy, obviously to prove all those things. These, whenever we're notified or, when you notify us about a potential claim or case. And hopefully, the carrier that you work with is receptive to getting even early reporting of situations where, you've been involved in a patient encounter and you have a really bad feeling about it, or, something has happened, or there's, you find out a patient has died, or, whatever. And, you may want to contact your carrier just to discuss some of the implications of that. And it's a way of capturing that information up front early on, and then your carrier can monitor to see whether or not a claim is actually filed at some point down the road, because there's a whole kind of a time clock or process that runs along these lines. These are the things that, that I look at, and these are the things that come up in our, dissection of cases when I'm reading, open cases and closed cases in terms of the actual story, which is very interesting, sometimes very sad, in terms of what actually happened with the patient, and where you start seeing that, they fell between the cracks, or, they weren't acknowledged, or, something happened where they just, and they end up, having a significant injury or possible death. And some of these things, though, could possibly contribute to some of those poor outcomes as well, and particularly with patients that sue in the office practice setting. We talk about medical records, very important. Follow-up, that's an area that I focus a lot on in doing assessments, and it's hopefully something that you have a follow-up system in place that works for you, that maybe your electronic medical record system assists you in following up with patients and keeping track of patients. Patient handoffs, there's so many caregivers involved in patient care these days. There are many opportunities along the continuum of care where, there's a handoff that occurs that may not be successful, that there could be a patient poor outcome or injury along those lines. Folks practicing outside their scope of service or practice, which would include, medical assistants, unlicensed assistive personnel, mid-level practitioners. How many people call their medical assistants nurses? Nobody's willing to admit it. But I do go into practices and they'll say, well, the nurse did this. I said, wait, you told me you don't have any nurses. Oh, I mean the medical assistant. But they'll refer to the medical assistant as a nurse. Well, a nurse and a medical assistant are very different things in my mind, and they probably might be in the patient's mind from that standpoint as well. So that goes to the issue of identification. Informed consent, refusal, medication management. We already talked about patient abandonment and those kinds of things. So telephone liability too, in terms of documenting calls that come in during regular so-called business hours, evening call, and after hours. There can be some important issues along those lines as well. The documentation, obviously it's the patient's medical record, it's their history, it's, it promotes continuity of care. It's the record that you've generated. You may have prior records from another provider, so you have all that information. And I know sometimes I get questions about, well, the patient has their record transferred to me. Am I responsible for going back thoroughly into that whole record and trying to figure out, what goes on? And sometimes, I mean, it's a difficult situation, because if you have that information, you may be obligated to be aware of what is in that information, from that standpoint. Medical record is the basis for communication among caregivers, so it's very important from that standpoint that people can look at the record and actually figure out what is going on with the patient. And I've looked at some hospital records and, electronic hospital records and practice records where I have a real hard time trying to figure out what's going on, in terms of, or there's repetitive or duplicative information because the record populates itself, and there's all this stuff you have to kind of wade through. And so I don't know how you guys are doing that as far as getting through all that stuff. It's a challenge in some cases, and hopefully, again, some medical record systems are better than others. And then obviously, it's a legal document, and it's something that, we use and that we would use in your defense as, as an insured, or with your carrier would use in your defense. So it has very important aspects along those lines. It's also used in, we've talked about claims, complaints and investigation, medical boards, health plans, they do investigations. And again, they're obligated to, as I said before, to do their due diligence and, look into these things and, talk to you, get a copy of the medical record, try to figure out what's going on with this patient's complaint and whether or not they have a legitimate complaint. And as I mentioned, you may have coverage through your professional liability policy to get legal counsel assistance in terms of addressing some of those things. Or maybe even your liability carrier is happy to review, a response or a letter that you might send to the medical board, from that standpoint. This is the problem, though, that poor medical record documentation is the leading reason a medically defensible malpractice case, and that's the key there, is medically defensible malpractice case, is settled or lost at trial. And, I think what happens there is that and I've had a defense attorney that I work with, he has a good statement that I quote to people a lot, and it's basically, don't let the documentation become the distraction, to the care that was rendered. Because the plaintiff attorney is going to look at every little thing that they can pull out of that to possibly make you look bad or careless or, non-caring or sloppy or whatever, with respect to the documentation. And they're going to focus on those things. Again, most situations don't go to a jury trial. Most things actually never go anywhere at all, for that matter. I mean, we get reports of a lot of claims, or ROC, a report of claim. Folks are concerned about a situation, they bring it to our attention. If they talk to me from a risk management standpoint, there may be things that I can say, okay, what's happening with the patient now? Who's communicating with the patient? Who's taking care of the patient? Okay, now I'm going to have you talk to the claims investigator because they may want to ask you and interview you about what happened because it's fresh in your mind right now. Because we may not know about this situation, it's unfurling over the course of months, weeks, maybe even years, and so we want to get all that information fresh. And then a lot of times, the carrier can track whether or not a claim is actually filed, so that it's not a surprise to us that, we've already done kind of some of our little upfront homework. So again, but most of those things don't go anywhere because, the statute of limitations runs. Somebody gets a plaintiff attorney to represent them. The plaintiff attorney goes, there's no case here, We look at it and we go, we don't think it's going to go anywhere, from that standpoint. But we keep it on record. We revisit it. We just check in to see, what's happening in the development. And then it eventually expires. So most cases probably, they don't go anywhere. Then the next level would be where they're settled, for whatever reason. And that could be a situation where we look at it and we go, we don't want to take this to trial because we don't really think we're in a good defense posture. We have some issues or problems, and it probably is more prudent to settle, in this case. And that's something that, obviously, with your carrier, you have agreements or consent agreements as far as how they represent you and how they, take cases to trial or settle, that kind of thing, and get your input in terms of how that case is going to go. But here we're talking about how documentation is really it's your main witness. It's really the thing that everything really hinges on, from that standpoint. I know that you've heard this all your lives in practice, that documentation is important. And now, as I mentioned earlier, you're facing the challenges of dealing with electronic medical records. And, we're all kind of on a learning curve, or most of you are, I would say, but we're all kind of on a learning curve at this point, too, because we're wondering, do electronic medical records help us in defending cases? Are we actually finding that, the records or the copies of records that the electronic system spits out, is that really helping us defend cases? And I've heard folks say, well, the good thing about electronic medical records is you can read them, and then sometimes the bad thing about electronic medical records is you can read them too. And, so there are things in the record that, it's like, wow, before we couldn't decipher what that illegible writing was, but now we can actually see what it says, and that's not really very helpful, or that's, somebody's insulting somebody else or blaming somebody else or whatever. So that's, those things that are in the record. And I just caution you all about that. I had a situation where I got a second opinion, and my doctor was very professional, and he said to me, he said, well, I know you have concerns about what the other doctor was doing, And I kind of understand where he was coming from. He didn't say this guy doesn't know what he's doing. He was very professional about it. He said, but if you want my opinion and if you want me to be your doctor, then this is what I would do. And again, I understand what he was doing. But now, if you want my opinion, that's how we're going to handle it. So that's where we go from this point forward. But you will find I have a large multi-specialty practice that I deal with in Southern California, and I know that when I've talked to the group with respect to things like e-communication and documentation, the medical director wanted me to bring up the issue about disparaging remarks about other providers and things like that. The medical record's not a place for that. And if there is an issue that you're legitimately concerned about, there are other channels to work that out rather than in the patient's record, from that standpoint. So again, you don't want those things, being kind of muddling the issue in the medical record. In God we trust, all others must bring data. And that was Demings, who's the quality guru, from that standpoint. A lot of times you've heard, too, that, well, if it wasn't documented, it wasn't done, right? I know working with hospitals, that was a big mantra for the nurses all the time with respect to nursing documentation. But I will tell you that, defense attorneys have told me that, well, yeah, it's easy to say that, and sometimes there are reasons why things aren't documented or overlooked or what have you, and we're not expecting perfection here. But in some cases where things are not documented, we're still okay because you have an opportunity to tell your story. And that might be in an interview or a deposition, those kinds of things. The issue, though, a lot of times is when, if you have ever been involved in a claim, was it your first inclination to want to see what the record said or what was documented in the patient record? If you received a notice of claim on a patient, would that be a reasonable thing that you'd want to do maybe? And a lot of people do, and then, they look at it and they go, oh, yeah, I kind of remember this patient, and oh gosh, now I really wish I had documented something that I now just remember, like this is months later or whatever. Maybe it used to be less of an issue when it was manual charting, although they had a whole forensics thing set up where they could determine when even things were entered in a record handwritten later on, because that stock of paper didn't exist at the time that this was documented. That stock of ink didn't exist at that time. They'd have like the whole CSI forensic thing investigating this record if they really wanted to find out, if there was some problem with the integrity of the record. Well, now, we have electronic medical records, and everything we do in there is dated, time-stamped, who goes in, who goes out. Nothing's ever really destroyed. Nothing's ever lost. But the thing is, your defense attorney, who's hopefully a good defense attorney, will tell you that they can work miracles too, and they will tell you that you will have an opportunity to tell your story, and they can work with some really, I had one defense attorney that I was working with where she put up 4 examples of the record, and in each one it was the same record, but there was differences in each one, and somehow she defended the doctor and explained his way out of it. But that's, but why make the attorney work that much harder, and that's part of where, you kind of want to try and make their job, a little bit easier from that standpoint as your partner. Well, this is the question I guess we're all asking each other right now, right? So, friend or foe. I think technology is great when it works. When it doesn't, I get very frustrated, because it's kind of, a lot of it's magic to me in terms of what it can do, but its capabilities are incredible. And I think that one of the things that when you are implementing your electronic medical record system, or you're working with an IT person or a vendor where you're trying to maybe optimize the use of the electronic medical record, have it do things for you that it's capable of doing. From the standpoint of generating reports on patients who maybe you've referred out for tests or consults, and they haven't done that, and you have a way of contacting them to make sure that they get that done, because you're kind of on the hook for follow-up along those lines. And does your system, can it do that, or do you have a manual system in place even just to make sure that some of those patients don't fall between the cracks? Friend or foe, before EHRs and, the stacks of paper and all that other stuff, and after, it's still, I still see people getting headache. I have a lot of people telling me that, oh, I'm not documenting less, I'm spending more time documenting. I'm spending more time, documenting in the record, or there's more of my office hours are consumed in that, from that standpoint. The changing landscape is that, there's kind of this continuum where, care is, the workflows changed by electronic medical records, communication, data that we're able to access, accountability and liability, and these things kind of feed off of one another. It's kind of like a continuous cycle there. And, really in a lot of cases, probably EHRs did challenge your workflow in the office in terms of how you did things, and you had to think out your processes to make sure that your EHR system could accommodate that. So, we're not talking here about, because again, I would say most of it, is everybody on electronic medical records now for the most part? So, and hopefully, again, it's working out for you, but these are the things that, and obviously, there are requirements and incentives for, and meaningful use and all those things that you're having to keep up with along those lines as well, too. New technology brings new approaches, new risks, new strategies, back to new technology. It's kind of a continuous cycle. And again, there are things that, that we do now with technology that we maybe don't think about a lot. And, when I'm talking about the medical record and documentation, well, for example, and I'm not going to stand up here and tell folks, stop texting your colleagues about things, because you're using texting to communicate, and you're not.
Oh, absolutely.
Okay? Why not?
Because I can't guarantee the privacy of message.
Right. Right. And I didn't make you say that. That's exactly right. Yeah. These are the things that, for convenience, it's great. And we have a whole talk on e-communication about these things, too. Maybe I'll have an opportunity to talk about that as well, and kind of, raising the roof on some of those things that folks are doing and not really thinking about, or thinking that there are some folks that think that, well, it must be protected, but it's not. It's not necessarily protected or encrypted. And so, you want to be more wary about what you're including in those texts, because are they even getting to the right recipient? Because if you're like me, I have texted my sister when I meant to text a friend, or vice versa, and I go, oops, I didn't mean to send that to you, and fortunately it wasn't anything incriminating, but, those are the kinds of things that can happen, and there are errors, and it could end up violating, patient's confidentiality from that standpoint. Not only that, but there could be important information that somehow is getting outside the channel of the patient's medical record. And that information might be very helpful, not only from the standpoint of patient care to be incorporated in the medical record, but also when it comes to defending that case, when we're looking at documentation and we're seeing things that are missing that might have been, might be outside of that. And, maybe there's ways to even access that information in text and that kind of thing. But, so the question is, to me, and I guess to everyone, is what really constitutes the patient's medical record in 2014? Because, there's email communication, texting, there's social media. And we talk about that in e-communications too, about people not thinking about the stuff that they're putting on Facebook, when they go home and they document their experiences at work today and what happened, and I had this patient that was difficult, and these are things that are opening themselves up to breach of confidentiality claims and things like that. And so there's a lot of that going on, and not to mention, I think we're all aware of just the ability of people to hack into systems and get information. Our financial information is so vulnerable, it seems to me, with respect to all the things that these big corporations and stores and things like that we're hearing about. When they're trying to get information from you all, they're not interested in the patient's health. They're interested in that, demographic information, driver license number, social security number, those kinds of things. And even when those things do occur, hopefully in this day and age, you have something what they call cyber liability coverage. A lot of times policies will incorporate that, or that's endorsed onto the policy, where if you do experience a breach of patient health information, stolen records, stolen laptop, whatever, if there's access or potential access, that, there's a whole process in place that you notify patients appropriately if that need be. You notify the consultant or the carrier that can help you walk through that situation and know what to do in terms of how to handle that. So, again, it does change our thinking and processing and our routines, along those lines. It used to be that I would hear these stories about how someone wanted to catch up on records, so they took records home and they left them in the car in the garage, and the garage was broken into, and now the records have gone. And and then sometimes I'd say, well, when did this happen? Oh, it happened like a month ago. And it's like, I kind of lost the opportunity, because maybe those records will show up before you've had a chance to do something about it. And I know it's not a comfortable discussion to say to somebody, your patient information may have been compromised, but I'd rather hear it from you than read about it in the newspaper, how somebody found a bunch of boxes of records in the Starbucks dump or something like that. And I actually had a picture, I wish I'm going to incorporate it in, where it was in New Jersey, of all places, a landfill, where they took a picture and there were all these boxes of medical files just sitting on a mound of trash, that anybody could have, and they weren't torn up or destroyed. They were all intact, as far as that goes. And, hopefully we're seeing less of that because, we have electronic systems. But then how secure are our electronic systems from hacking and inappropriate or unauthorized access and that kind of thing? These are some of the things that are, I guess, weaknesses related to medical records where there may be inaccurate information, carrying over information. Sometimes there are templates that populate, and sometimes when you look at a record, and I looked at records, it's kind of repetitive. And it's like, well, these visits, they all seem to be very, very much the same. There's no really customization sometimes. And I think that's something that a plaintiff attorney is probably going to hone in on and say, who's really, what's really going on with this patient? The documentation seems to be not adequate from the standpoint that there's a lot of documentation there, but it's not really applicable maybe to the patient. Or are you, when it populates all those things that you would do in a normal visit, are you actually doing all those things because you may be billing and coding and billing for those things? You don't want to run the risk of not doing those things and then have, fraud from that standpoint. And I know that, there's a lot of information now that the government's making available, from CMS on medical records, and a lot of attorneys are wanting to look at records to see if doctors are committing any kind of fraud with respect to billing or overcharging or billing for services not rendered. So there's that whole kind of thing that's going on. So hopefully the medical record is not going to cause that kind of problem for you. There's fraud issues, default entries, the fact that records become copying and pasting. I know one hospital I worked with, the vice president of nursing just forbid, they took out the copying and pasting function because it was just rampant. And she said that, their medical record documentation, what was on the manual system was superb, but when it went to the electronic system, she said, we're having all sorts of problems, and I was addressing actual new residents, and we were looking at medical records, and I don't know how they, again, trying to wade through all that repetitive information, and some of the information I would be looking for or that I think would be important in the record wasn't there, or it was, pretty obscure from that standpoint. Metadata, that's the data behind the data. We're hearing more about that. Whenever they do a crime investigation, they seize computers and things like that because they want to know what was going on, what was that person doing on their system. And even though they've deleted things and what have you, forensics can still call that stuff up and find out, who they were communicating with, what websites they were visiting, all that stuff. The same with, and I don't know that it's really gotten to that point, but it might at some point, where plaintiff attorneys not only want a copy of the record, but they also want the kind of the paper trail, although it's the electronic trail of who went in that record at any given time, what was done, what was deleted or what was attempted to be deleted or what was added or altered. It's reasonable to put in late entries into a medical record, but you have to consider what's reasonable as far as late. A couple days, a week, a year is probably not appropriate, at that point. I mean, I think and that kind of thing, when there is that kind of addendum or late entry, it kind of throws the whole record, the integrity of the whole record into question. So it's better to just resist the temptation, and again, you'll be able to tell the story. And I know that if you have been involved in a suit or a claim, it's very intimidating, and you get this really nasty indictment that says all these terrible things about you and the terrible things that you did to your patient, and I don't know how you don't. I would take it very personally. I don't know how you don't take it personally, because that's not what you do. You don't get up in the morning and say, gee, which patient do I think I want to hurt today? That's not your perspective. And you're trying to help patients, but then, in a lawsuit, it really makes you out to look like the bad person. So again, this metadata, it's accountability because of who's going in and out of the record, who has access, and do some of those individuals that have access, should they have access? There are some groups or practices that limit what sections, the providers pretty much have free reign, but the medical assistants and other, or receptionists and those folks may have limited access. They don't have access to all the other things, within the medical record, because they really just don't have any business being in there or really have any need for using it, from that standpoint. And again, these are the kinds of things that can be discoverable in a case. So, it's really important, I think, from the risk management recommendation standpoint, take a look at, if you do peer review or if you do audits of records, to look at the quality of the documentation. Is it serving your needs? Is it serving your patient needs? And also look at it from the standpoint of, if possibly this patient sued me, and I'm just asking you to do that, how would this documentation stand up? Do I think I would have a good chance of defending my care through the documentation that's in this record? And, would I be able to provide appropriate information and rationales to my thought process, and, what I ruled in, what I ruled out, and, how I was treating this patient? And I know that requires some time on your part, but it's something that, you can do internally, or you can get assistance with that in terms of, or have your carrier, look at your records in some cases, just to kind of see what's going on from that standpoint. Having policies and procedures as to who, again, can enter things in the medical record, or what they can and cannot do, from that standpoint. Standardizing, documentation that some practices I've gone to where everybody's using different systems or templates or things like that, and maybe in the practice it's a good idea to standardize your documentation as much as possible and not have people working around the system to try to do what they want, And if there's a change in the system that's required, hopefully you have IT support that can help you make those changes appropriately. The other thing hopefully you have is good backup for your system, and not only on-site but off-site. Now, some of you may use a cloud-based, so you have like the virtual cloud, and then some are actual servers. But you have to have, usually it's good to have some kind of a duplicative system so that, if fire, flood, hurricane, tornado, whatever, that you do have appropriate backup from that standpoint. Because I've been dealing with some issues along those lines where folks, as part of the package, they thought backup was included, and then all of a sudden they have their system crashes, and they don't even know the patients they need to contact. It's really very complicated, and it's a terrible situation to be in from that standpoint. I see somebody shaking their head, so I don't know if you've had experience or you've heard about that kind of thing. It's a nightmare. Right, exactly. Yeah. But then again, with the cloud, now we're starting to hear how people are hacking into the cloud. So how secure are these things? From that standpoint. Medical record security, unauthorized access, disposal, loss, and breach. Again, these are issues that, I think one of the most famous cases, and this is something that, obviously departments of health and, the government are looking at HIPAA violations, unauthorized access. One of the most famous cases I remember being in California does everybody remember the Octomom case? Well, it was a Kaiser facility, and they got fined significant, like in the hundreds of thousands of dollars for patient breach of confidentiality because it was in the news and this person was a celebrity, so to speak. There were all sorts of staff members in the hospital who had no right of access talking about it, but then also actually accessing the record. So then they could go back and they could figure out on an electronic system who was going into the record. Well, why is that person really has no right of access to that? They were not involved in the care of that patient. What is their, there's no need for them to know anything. They're being, it's just inappropriate. And these, when they get fined these significant sums, I would think that they would rather use that money on enhancing their hospital or their practice rather than paying out these, fines, which are significant amounts of money. So, again, that's something that's definitely on our mind, and we definitely want to make sure that we've got good security and backup along those lines. Obviously, the EHR, involves the training, and of course a lot of that has happened, but then there may be new things or new features that are added that you want to make sure that staff are aware of. We talked about the access issues and policies and procedures. Again, real straightforward things that kind of reinforce around the area of documentation and medical record access, because again, it is so important for all the things that you do and how we defend cases. Organization is important too, because things that are out of skew, it makes it hard to defend cases along those lines. Errors, misses, and again, it's problematic for patient care and safety if records are not organized or if important information is not transparent when you go on or it's hidden or you have to search for it. That could be a problem. Also having, protection of sensitive information in records. There are many laws in states that protect things like HIV tests and outpatient mental health records and things like that. These have to be just like they were in a manual system, in the electronic system. We want to make sure because, someone may just say, push that button and print out a bunch of stuff, and is somebody making sure that, at least in the paper file, you might have had a separate section that said, confidential, do not copy. Well, do you have the same kind of thing in your electronic system that prevents you? So you want to make sure who's ever, reviewing the records or responding to record requests that they're not sending out information that could get you into trouble because that information shouldn't be released. So you have to have those kinds of safeguards in place, from that standpoint. Follow-up. This is really important. This cartoon, it's a simple stress test. I do your blood work, send it to the lab, and then never get back to you with the results. Okay? Now, hopefully that's not the case. But, someone from the New Yorker felt that it was funny enough, or maybe that was their experience in the doctor's office. But there are situations where, sometimes folks will say, well, if you don't hear back from me, assume everything's okay. And I've been in that situation, but I still, because I'm in this field and I'm a risk manager, I call, oh yeah, there is something. Well, I didn't hear back from you. Oh no, but there is something, So I'm a pain in the neck when I ask you about how, do you provide results, abnormal and normal results? Do you follow up with your patients? And some of you have different ways of handling it. Some of you don't want to discuss results over the phone with the patient. You'll actually have them come in person. Some of you will, contact patients just on abnormals. Some will delegate to someone else to call about normals. I think, it's something you want to work out in terms, as long as it's appropriate that person can do that. I think you want to kind of close the loop on that so that patients do have an understanding, because the issue comes up, well, I didn't hear anything, or, and I didn't think to call, but they told me if there was a problem, and I've just seen too many cases where there was, and it wasn't communicated. Somehow it got misfiled, went into the wrong record, wasn't reviewed, whatever, from that standpoint. And then it leads to what it results in, basically, is we've got the big issue with, one of the leading malpractice allegations is failure to diagnose or delay in diagnosis. And a lot of it's tied back to, the lack of follow-up systems that are in place. And that's kind of a general thing across the board. And so it's really, and again, that's something that when we look at, dissect a case and we go, wow, if that patient had been notified or if they had gotten back in for a follow-up or, and I know sometimes it's difficult when you have non-compliant patients who don't respond to your calls to come back. And then, so what do you do at that point? I mean, because their inaction or non-compliance is becoming your liability now. So you want to protect yourselves and make sure that, yes, I've contacted the patient, I've contacted them a couple times, I sent them a letter, whatever, however you do it, but have that documented, have that in the record. Is there a magic number that says you have to contact them 5 times and you can give up? No. I think, a couple legitimate ways of doing it. And sometimes I think you also run into the issue with people being transient where you try to contact them, wrong phone number, wrong address, wrong information, and just document that stuff. You made the attempt. I don't think that there's an expectation that you go above and beyond that, but you do make an attempt to try to rein them back in, from that standpoint. I already said this, delay in diagnosis, failure to diagnose. And again, that's something that, it could prevent a lot of poor outcomes. These are things that, the outcome would be very different from that standpoint. Here we have this was just a case study with follow-up with a 77-year-old female smoker. Chief complaints, shortness of breath. The primary care physician referred her to a pulmonologist. Pulmonologist did a CAT scan and found masses in the left and right upper lobes. The results of that, though, were put in the medical record, and it was documented no evidence to explain shortness of breath, and there was no recommendations or really any follow-up with that patient. 2 years later, the patient was hospitalized for shortness of breath. The upper lobe mass grew, and the diagnosis was non-small cell lung cancer. There was a lobectomy, and there was metastasis to the liver, and the patient died 5 months later. Well, in that case, what happened was, and I believe that, there was a suit filed by the daughter, obviously delay in diagnosis. There are some cases where, in this case, they could make the argument that there was a duty and there was a breach of that duty, and that the breach, resulted in an injury that, or resulted in the cause of an injury. The plaintiff was able to prove that, and basically, going back to that, I think in this case what happened was this was a situation where lab result or the CAT scan results came back. They were filed in the record, but nobody had really reviewed or signed off on them. And one of the things that in your system you want to make sure that you have a system in place that you get those, test results, lab results back, that how do they, they may come back hard copy, they may come back electronically if your system's integrated with an electronic system like LabCorp or Quest. However those things get into your electronic system, whether they're scanned in or they enter electronically, there's got to be a way for you to be able to indicate on that test result that you reviewed it, you initialed it, and then you file it in the patient record, and you make some disposition with that in terms of what kind of follow-up happens with the patient. I had one practice where I went to visit, and this doctor had been sued for a prostate cancer case situation. And so he had an electronic medical record system, and he had, this was where he had hard copy results that were faxed into the office. What they would do is the staff would take the hard copy and immediately scan it into the record without, the doctor hadn't reviewed it. They'd scan it into the record, so the hard copy was in the record. And then they would give the hard copy to the doctor, and he would make notations on it, and I'm concerned about this, call this patient, da-da-da-da. And once they were done doing all that stuff, they'd throw this out. So the only thing that was in the electronic record was the blank copy, And in a case, that information could be really crucial, some of that handwritten information or whatever. So I said, well, let's just kind of change the system here. Just when it comes in, give it to the doctor, make sure, he does whatever he needs to do with it, and once all that's, then scan it in, and then you've got it all there. It's a relatively simple thing, and I'm not saying that the practice was careless, but again, I guess they're not necessarily thinking of it from the standpoint of potential lawsuit or professional liability. because they did what they thought they had to do with the patient, but they want to have that backup documentation along those lines. So, in this case, that was the downfall here, and there are so many situations, where that happens, where there's just patients are lost to follow-up because of, the channels of communication get kind of convoluted or very complicated sometimes. And, we have electronic systems, but they're not all talking to one another, and so we've got this kind of complicated thing going on. I mentioned earlier the continuum of care, just to impress upon everybody that, there's so many folks that are involved. We even do like a special presentation on handoffs along the continuum of care. And it just talks about where there are, so many areas where there's potential for breakdown, particularly, when a patient comes into a hospital and they're moved around and, there are various, there's a hospitalist taking care of the patient, the hospitalist refers the patient to specialists, and all these folks are involved, and are they basically doing appropriate handoffs? Are they communicating the right information? Are they signing off on patients appropriately? And that's a whole other area that, many of you, I don't know if you, some of you may not admit patients to the hospital. Some may just leave it, patients are admitted through a hospitalist program in the hospital. I'm finding that to be more and more the case. But if it's your patient, do you get communication from the hospital or the hospitalist once that patient is discharged? There may be those kinds of things that are happening that you want to make sure you're getting, follow-up or documentation on those patients. And, really the primary goal of the handoff is to transfer accurate and sufficient patient information to the oncoming provider and clearly define who's in charge of the patient's care. And that's something I see in, when we're looking at a lot of those handoff situations, is that at any given moment it was never really clear who was actually in charge of that patient. Many people were doing things, but it was all fragmented. There wasn't, documentation. There wasn't communication among providers. People were making assumptions. Well, I'm not doing it because I think so-and-so is doing it. And it just, when you get back, and then, of course, the tragedy happens, and you dissect the story, and then you see, again, all these things that could have been prevented. Again, it is a challenge. Basically, it's really important in documentation to have, chief problem lists so that there's a summary of what the patient has been or is being treated for, the review of records and tracking, the patient's whatever system, again, whatever system that whether it's a manual tickler system or an electronic system. I've been in some practices where they have an electronic medical record system, but they have a manual system as a backup. Sometimes that's another thing that too, many times your systems may go down. I don't know if you've had that experience, and you have to kind of revert to manual until you can get your system up and running again. Then you have to play catch up and get everything in the system. So there are all those kinds of things that can happen. Telephone liability, that's a whole area that, we look at in terms of, there are a lot of folks that are in your practice that are on the front line, that are receptionists, that are taking calls, answering questions, making appointments. That's all part of, again, too, not only the medical practice, but kind of their customer service experience as well, in terms of how they're treated. Because patients can't necessarily evaluate the kind of medical care they get because they're not physicians. They're relying on you to provide that, but they know how they're treated. They know how people talk to them. I hear so many times where, patients complain, someone was rude to me, someone was abrupt with me, someone was having a bad day and they took it out on me. Those kinds of things can happen. And obviously, and then it kind of harms your reputation too when you have staff that are not, treating patients appropriately. But, then again, they're faced with patients that are abusing them sometimes too. And you've got patients that, I hear about situations where, patients are physically abusive, intimidating, verbally abusive, inappropriate language, shouting at everybody. And when we were talking about patient termination, I would say that in some cases, you don't necessarily give them that 2-week grace period when they're that way. I know patients have rights, but if they're physically threatening to you or your staff, your obligation is to protect yourself or your staff or other patients. They've kind of, gone, over that threshold. And again, I think that's something that you might want to call your carrier about, because I was told that when I was talking about this in Texas, They told me that even though that's the case, you still have to give them like a grace period. Even there's a way of dealing with it. And I thought that was interesting because I thought, really I've been telling people, at least some of the folks I've been dealing with, that these people will say, I know where you live, well, they know where you practice, and they show up. And if they don't have an appointment, they're essentially trespassing, and if you've terminated a relationship with them, you might want to call the police because they are on the premises. They don't have a right to be there. So anyway, that's, how did we get to there from telephone liability? Well, we're just talking about, communication in general. And, again, it's important to capture all the calls that come in that could be very important in terms of questions that come in from patients about seeking information or medical advice, making sure that those that are answering the phone are rendering appropriate information but not overstepping their bounds by giving medical advice that's beyond their scope of service or practice. If they're not medical professionals or mid-level providers, you don't have medical assistants giving medical advice. So there's that whole thing about triage versus screening. Triage, in my mind, is a higher level of, determining the priority of a medical condition and that kind of thing, whereas screening, that would be an opportunity where you might have someone who is answering the phone has kind of like a script or a grid where there are commonly issues that are commonly called in, and basically they have a kind of a protocol they go through, and they know who to refer that call to and when to refer it, and time can be of the essence from that standpoint as well.
Right.
Yeah.
We've got about 15 minutes.
Okay. Thank you. Thank you. Okay. Well, I will jump into. Let's see. Is this a? This was just this situation here was I could talk about this stuff all day. So I don't even want to hear about it all day. But anyway, this was just a case where you have a 48-year-old male. The wife is calling in to different doctors in this practice, and essentially the bottom line is that. What happened was the allegation was substandard care, negligent care, and treatment resulting in patient death. Because you had all these days where I think that the wife called in because of her husband and got a different physician, and somehow the documentation, these encounters on the phone were not documented, and there wasn't communication, even verbal communication among the providers. And you look at that and you go, how did that happen? Even they're in this small practice and there was lack of communication. We normally might expect that in a maybe a big practice, but here it was happening in a small practice. The patient ended up in the ED with sepsis and death because of all these symptoms that were reported that should have gotten some attention and follow-up, and that just didn't happen. I already talked about some of these things already, so I've kind of gotten ahead of myself on that. Policies and procedures for your, particularly for unlicensed assistive personnel, medical assistants. Some states highly regulate what medical assistants can and cannot do. And you should be familiar with that because, I know that when you go into your various, nursing board or, physician board or mid-level provider, it's pretty well outlined in terms, what licensed folks can and cannot do, but with unlicensed individuals, it's sometimes very vague. And then sometimes folks start using them to do things which are beyond their training or their scope or their capability. And, that's kind of, and if you're putting them in the position of actually, practicing medicine or giving medical advice, that's where you can get in trouble because you're responsible for managing them from that standpoint. Medication management, real quick. This issue, was problematic, I think, with manual charting and sometimes difficulty in reading or decimal point placement or miscalculation, drug identity, monitoring, knowledge. These are the common issues that occur. And, in your medical record systems, you may even have prompts now that, when you're prescribing a medication, it'll give you a recommended dose for the patient's age, whether it's a child, whether it's an adult. And so, there are those things, those kind of risk management prompts or whatever that can help you in terms of, are you sure you really want to do this? That kind of thing. Hopefully that's helpful. This was just a situation where a patient It was the key on this point was that the patient had an allergy to sulfa. The patient did have a urinary tract infection, was prescribed sulfa, because the doctor in their electronic system had shut off the allergy alert warnings in the system, so it didn't come up. And this had been documented in the record like 8 years prior. So there was a permanent scarring as a result of this patient getting, a severe rash and blisters and was hospitalized because they shut off the alerts. Negligent prescribing of medication to patient with a known allergy. And obviously, on the manual charts, we used to have, stickers or things like that that drew our attention to that, and we want to make sure that the electronic medical record as well. Allergies prominently notated, medication lists, prescription policies and procedures as to who can refill, who can call in, the pharmacy, who can send to the pharmacy. All those kinds of things have to be regulated. This was just a tragic case because it was in a situation where this patient was a 49-year-old male, was going to the primary care physician for a glaucoma test, and they were using, I forget the exact drops to test the pressure on the eye, but that little bottle was next to the Hemocult developer, and that was put in the patient's eye. So the patient ended up with severe pain, irrigation, and referred to the eye clinic. Negligent administration of incorrect medication resulted in eye injury. And upon review of this doctor's office, it was just really disorderly. It was messy. Things were just cluttered. It's not organized. And these are the kinds of things that basically a little cleanup could lead to, something like this not happening. And making sure that things that look similar are definitely separated, within the office from that standpoint. You've got things labeled appropriately, separation appropriately, organization, multi-vial use, the date when it's first used, expiration dates on that, important. Informed consent and refusal. Again, we're going through this laundry list of things, and I'm around to answer questions afterwards if you have questions. I talk about informed consent, and that's really important. We talked about that a little bit on the pain management side, or with any kind of maybe in-office procedures you do, or procedures that you do outside of the office, surgery center, hospital, whatever, that you have your informed consent document. And it's not just a document. The thing about informed consent, it's a discussion. It's education of the patient. It's making sure that they can make informed decisions, when you provide them with the appropriate information as to whether or not they want to undergo a procedure, and, if there are risk benefits and alternatives. We know all that stuff, and we know it's important to document that. Having a form that they sign is helpful, but the form that they sign, just throwing a form in front of somebody and saying, sign this, really isn't informed consent, unless it's really that verbal discussion takes place and it's backed up. The other thing, too, is you may have patients that refuse procedures. Do you have anybody sign an informed refusal form? Kind of like informed consent, but they're just saying, my doctor has recommended this test procedure, whatever, but for whatever reason, I'm declining that. And then you have that as part of documentation because he or she has made me aware of the risks and the consequences, anything up to death, that could be an outcome here. And you have that as part of that education and documentation that the patient understood that. Because so often it happens that we're looking for informed consent in a case and it's not there, and it kind of becomes a secondary issue, or we're looking for informed refusal from that standpoint.
Brad, let's do this. We're getting close on our time.
Yeah.
Maybe I see your slides. You've got the topics. If you can just kind of go through and give us the topics. Yeah. And then
those are the case studies.
And we'll have those on the website.
Everybody gets these slides. Okay. Good. Yeah.
And, the mid-level practitioners,
right?
And there's an area of problems, and then medical assistants, and
and we've even already talked about some of those. I'm kind of doubling back on myself. It's hard to talk about one thing without another, and basically these are the important aspects of scope of practice is important in this, and I think where if you are working with mid-level providers, nurse practitioners, PAs. There are delegation of services agreements in place. There are collaborative agreements in place that are not just boilerplate, but they're specific to the practice and your relationship with that mid-level provider. And also, you may have a system in place where you How often do you review medical records of the physician assistant? There are supervisory rules are different from state to state in terms of how many mid-level providers or physician assistants one physician can supervise at any given time. Well, they're unlimited here, but then I know like in some places it's 4, sometimes it's 6, some places it's 2. The thing about that is we've seen a lot of cases where sometimes a mid-level provider maybe was operating maybe too independently and maybe should have referred a case to their supervising physician for consultation, and they failing that, then they got into trouble. And so, we've seen that kind of thing where maybe sometimes there's a policy in place where on every 3rd or 4th visit, the patient is seen by, sometimes they're seen both by the PA or the nurse practitioner and the provider, but sometimes if they're seen independently by the nurse practitioner or PA for a couple visits, then they're seen by the doctor, on a certain visit. Yeah.
You're touching on one of the most important points of your lecture, the first part about prescribing and narcotics. Now, ancillary personnel can prescribe these. The second thing is determining who is abusing drugs. There's nothing like the doctor sitting down, talking to the patient, listening to the patient, and doing the history and physical, perhaps from a form, but doing it personally. Mm-hmm. Whereas nowadays, ancillary personnel take the history, write it down, and that's it. And the last comment about seeing the doctor every 2 or 3 visits is just very, very poor practice and wouldn't stand up in any court. Mm-hmm. You go in there, you're going to pay the doctor, he's responsible. He should see the patient every time they come there. Mm-hmm. And if you can't do that, he shouldn't be practicing.
But I'm aware that many don't. Many, they will have the PA or the nurse practitioner see the patient independently. They even they'll have a satellite office where the PA or nurse practitioner operate, and the doctor is not on site in that office. Well, but I know it's
not the proper practice of medicine. That's not
Brad, why don't we stop here? We've got just a couple of minutes left before we have to take a break for lunch.
Pretty much got through everything. And, medical assistance we talked about. Yeah.
These will be on the website. Yeah. And if there's a couple more questions, we've got a few minutes. Maybe we can go to the microphone so the folks that are on the webcast can hear.
Let me get to
this. It's really good content, and a lot of the rest, it looks like it's supervisory type things that you can't let your nurse practitioners, PAs, medical assistants run wild, and you've got to monitor them.
Well, I think it's important in terms of having a very good communication within the office, collaborative arrangement where everybody professionally is working together and talking about some of these issues where they face, and that they're not afraid to talk to you about things that they're concerned about or where they may have liability, because obviously a medical assistant, they don't have a license, but, actually your license could be on the line if they do something that's inappropriate or beyond their scope, or you're sued and they went, beyond their scope of service from that standpoint because you supervise them or manage them. So these are the things that, again, we see, quite often, and it's really, I think what happens is that some folks have had, they've been in practice with a staff for a long time, and they just feel very comfortable that, that person knows how to do that better than anybody, but maybe they shouldn't. In California, there are some things that if they're having, the medical assistant do certain things, it actually is illegal because it basically absolutely says they cannot. There are limitations on that. So there are just some case studies in there that talk about how a medical assistant was giving advice over the phone to a mother saying, the mother calls in with a child that has fever. Something's going around. Try this. And so the doctor is never made aware of the fact that the mother called. The mother is taking the medical assistant's advice. The patient ends up, has meningitis or something like that. And the doctor was never given the opportunity. You want to make sure you're getting that information, that someone's not bypassing it or trying to handle it for you. And we already talked about patient abandonment, the whole process of going through that. Billing and collections. The only thing about that is, when you're sending a patient maybe to collections, make sure that if you're using like a third-party biller, that they may send the patient to collections, but maybe you've got a lawsuit with that patient. You want to make sure that you're not making the patient even angrier, from that standpoint. So there should be an employee identification I talked about. Sometimes folks require name badges. call people by their appropriate titles. Don't call medical assistants nurses, that kind of thing. And that's the gist of it. There's a lot, there's a lot out there, and I think I'm all talked out. But anyway, I appreciate your patience, and I'm definitely here to help answer questions. And if there's any information, you can contact me on that website and phone number. And if there's anything that I talked about, or if there's anything you disagree with, I'd like to hear about that too. And I think that you have evaluations that you all fill out as well too. So really find your input helpful to make these programs better, helps me do my job better, learn what's on your mind and what's going on out there, because I learn from you guys all the time. I highly admire what you do. I don't know how you do it, but keep on doing it, and very good. Thank you.
Thanks so much, Brad.